Good afternoon. My name is Matthew Clay, and I'm with JBS International. Thank you for joining us for today's webinar, Preventing and Addressing Xylazine Use in a Behavioral Health or Clinical Setting. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A window. To open your Q&A window, please click on the Q&A icon that's located in the bottom center of your Zoom screen. Closed captioning is also available. To turn on closed captioning, click the CC icon that's also located at the bottom of your Zoom screen. If you experience any technical issues during this webinar, please message us using the chat feature, which is also located at the bottom center of your screen, or you can email us at samhsastateta@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be available and sent to participants at a later date. Next slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. Next slide. So as you can see from our agenda, we have a jam-packed day in front of us. Today's webinar will include several different speakers providing different perspectives all along the topic of preventing and addressing xylazine use. Folks will have the opportunity to again submit questions throughout the webinar using the Q&A feature as well as the chat feature that's located on the bottom of your Zoom screens. Next slide. At this time, I will introduce our speakers for today's webinar. Dr. Neeraj Gandotra is the Chief Medical Officer for SAMHSA. Dr. Gandotra began his addiction career in public health by training within an underserved community in Washington, D.C., where he developed his perspective of how a nationwide approach to local addiction treatment is needed. Later, as Medical Director of Addiction Treatment Services at Johns Hopkins, he directed and delivered care through the implementation of department initiatives and medical center resources. At Johns Hopkins, he also managed the administration and clinical treatment within an opioid treatment program multidisciplinary team setting. Immediately prior to joining SAMHSA, Dr. Gandotra served as the Chief Medical Officer for a large nationwide addiction treatment network, where he has developed national strategies specifically aimed at reducing risk, improving outcomes, and provider development. Dr. Chelsea Schofer is an assistant professor in residence at the University of California, Los Angeles School of Medicine in the Division of General Internal Medicine and Health Services Research. Dr. Schofer completed her PhD in epidemiology at the University of California, Los Angeles, and a postdoctoral fellowship in psychiatry and behavioral sciences at Stanford University. Her research focuses on addiction, infectious diseases, and their shared social and structural risk factors. Dr. Joseph Friedman recently finished an MD PhD at the University of California, Los Angeles, and is an incoming resident physician in psychiatry at the University of California, San Diego. Dr. Friedman also completed a master's in public health and a 3-year data science fellowship at the University of Washington. His recent research has focused on characterizing shifts in the epidemiology and social characteristics of the U.S. overdose crises, including a changing profile of synthetic substances involved, tracking demographic shifts and racial ethnic inequalities. He's published over 65 peer-reviewed manuscripts on these topics, including first author publications in the New England Journal of Medicine, Nature, and The Lancet. During his doctoral work, he authored several articles describing the spread of xylazine, using qualitative and quantitative methods, and he currently has several active projects related to its epidemiology and clinical management. Next slide, please. I'm now turning to Dr. Gandotra to get today's webinar started. Dr. Gandotra?
Thank you, Matthew. Good afternoon, all. On behalf of SAMHSA's Center for Substance Abuse Treatment Director, Dr. Ingvild Olsen, and our Assistant Secretary for Mental Health and Substance Use, Miriam Delphin-Rittman, I would like to thank our presenters, Dr. Shover and Dr. Friedman, who've been at the forefront of contemporary research on xylazine. I'd also like to thank our contracting officers at SAMHSA and JBS International for putting this activity together. Most importantly, I'd like to thank all of you for being here and for all the work that you do and the work that you will be doing in partnership with SAMHSA and HHS in combating this crisis. The Biden administration declared xylazine-laced fentanyl an official emerging threat to this country, and this is the first time such a label has been given. And the DEA reports seizing xylazine and fentanyl mixtures in 48 out of 50 states. As this emerging threat has surfaced, HHS and our state and local partners have been marshaling resources for communities to help combat this new aspect of the overdose crisis. For example, through harm reduction and state opioid response grants, we have provided funding to be used for xylazine test strips for sample testing. Today, we will review our current understanding of the prevalence and impact of xylazine throughout the country. Next slide. I'm going to give a little bit of background before I turn it over to our experts. Xylazine is the active ingredient of an approved animal drug for which the FDA originally approved in 1972 as a sedative and analgesic. Xylazine is not approved for use in humans, but has been reported as an adulterant in increasing number of illicit drug mixtures. It's also been detected in a growing number of overdose deaths. It is most commonly encountered in combination with fentanyl, but has also been detected in mixtures containing cocaine, heroin, and a variety of other drugs. The limited scientific research that was initially available on the effects of xylazine on the human body and anecdotal reports suggest that users experience effects similar to opioids, but currently there is no standardized treatment. Thus, further research may be needed as we seek to improve the care of patients who have been exposed to xylazine. Xylazine is a non-opioid sedative, analgesic, and muscle relaxant, only authorized in the U.S. for veterinary use, according to the FDA. It is a strong synthetic alpha-2 adrenergic agonist, synthesized in 1962 in Germany as an antihypertensive, analgesic, hypnotic, and anesthetic. It was not approved for human use due to severe central nervous system depressant effects. Xylazine, acting as an agonist at the alpha-2 receptors, decreases the release of norepinephrine and dopamine into the central nervous system, resulting in effects such as analgesia, sedation, and muscle relaxation. It is not currently a controlled substance under the U.S. Controlled Substance Act and was first noted as an adulterant in Puerto Rico in the early 2000s through DEA reporting and laboratory analysis. It has been legitimately sold through pharmaceutical distributors and internet sites that service veterinary clinics and veterinary services. However, xylazine has also been readily available for purchase on other sites in liquid and powder form. Then those sites often have no association with the veterinary services, nor do they have any requirements for proving legitimate need. Xylazine can cause respiratory depression, slowed heart rate, hypotension, and bradycardia secondary to vagal stimulation. Severe intoxication from xylazine has been reported from many routes of administration, including ingestion, inhalation, and injection. Acute symptoms can include prolonged sedation, blackouts, disorientation, blurred vision, dry mouth, hypotension, and respiratory depression. Chronic use can lead to severe skin wounds, dysglycemia, and abnormal blood sugar values, as well as anemia. In addition, when it's used with illicit opioids, it can potentiate sedation and respiratory depression and increase the risk of fatal overdose. Taking opioids in combination with xylazine or other central nervous depressants such as alcohol and benzodiazepine increases the risk of life-threatening overdose. So using xylazine and drug mixtures really does place individuals at a higher risk of fatal drug poisoning. And because it is not an opioid, naloxone does not reverse its effects. But I must emphasize that experts always recommend administering naloxone if someone might be experiencing drug poisoning. One of the most dramatic things seen with xylazine has been the wounds that are associated with chronic use. And those wounds are associated from xylazine use result from reduced skin oxygenation and vasoconstriction of the blood vessels. And chronic intravenous use of xylazine in combination with opioids has been associated with physical deterioration, dependence, abscesses, skin ulcerations, which sometimes progress to necrosis. And these can be physically debilitating and painful. Hypertension followed by hypotension, bradycardia, and respiratory depression lower the tissue oxygenation in the skin. Thus, chronic use of xylazine can progress to skin oxygenation deficits, which really means that they're not getting enough oxygen, and that leads to skin ulceration. And then that also impairs healing of wounds and increases the risk of infections. In severe cases, amputations must be performed on those affected extremities. As I mentioned earlier, there's no standardized treatment, and there's no specific antidote to treat people who overdose on xylazine. But again, I emphasize that we recommend that naloxone should be administered if someone might be suffering from drug poisoning, as there is usually concomitant opioid use. We need educational capacity building efforts for people who use drugs, the community around them who may witness such poisonings, special populations such as individuals leaving carceral settings, healthcare providers, harm reduction staff, as well as obviously first responders. This education should focus on best practices to address overdoses due to xylazine and including overdoses with concomitant other substances. That was a brief overview on the background of xylazine. I'll now turn it over to Dr. Shover for her comments and thoughts.
Wonderful, thank you, and thanks for pulling up this slide. Right, so I would like to start with talking about what we do know about the distribution of xylazine based on the data, but I will spend probably a little more time on what we don't know and why, and what kind of data we're missing. And then my colleague, Dr. Friedman, will get into a lot of the work that some of it we've done together about trying to get a better understanding of that. So what we do know about xylazine, we know that the adulteration of xylazine into opioids like first heroin and then fentanyl really started in Puerto Rico, then really expanded in the US mainland, centered around Philadelphia, and has expanded outward from there, where we still see in the most recent data. Now, this is age-adjusted overdose death rates from 2021, so it's a bit old, involving xylazine, and we see the highest rates in basically the states that are closest to that Philadelphia epicenter, and it disseminates out from there, but the rates were much lower in the Western US as of, at this point, 2.5, 3 years ago. But we know that xylazine's presence is increasing in other markets. For example, I run a toxicological testing program, also known as drug checking, where we're testing people's illicit drug samples. We're using xylazine test strips as well as a portable spectrometer and confirmatory testing with lab-based mass spectroscopy, and we are seeing xylazine emerge in our area in Los Angeles, where I'm based, and that really mirrors emergence, and in fact has been emerging more quickly in many other parts of the state. So this map is a good gestalt of the relative prevalence, but the actual numbers are probably much higher now, are almost definitely much higher now. So why so much uncertainty? I mean, I think that overdose data at the national level in the US is famously can be delayed. But for xylazine, that's even more true. And there's a few reasons for that. One is that the big one is that there's not an ICD-10 code for xylazine. So when deaths involve when xylazine is found found to contribute to death, it's not the same as with heroin when you can say, oh, I want to pull out all deaths that involve code T40.1. There isn't that for xylazine. And so you only can track it if you're looking at literal text, basically, of either death certificate, which in most places, a substance is only making it onto the death certificate if it's determined to be contributing. And in many cases, or most cases, I know that one analysis that Joe and I did recently found that of 918 deaths involving xylazine during a period that we were studying, only one of those didn't also involve other drugs. And predominantly that other drug is fentanyl or drugs related to fentanyl. So the question of how much xylazine contributes is a little bit controversial. And because of differences of opinion differences of judgment and opinion and limitations in testing, if quantification is not performed, when someone dies from an overdose where there's fentanyl and xylazine, if you don't know how much xylazine is on board, it's hard to know whether that xylazine contributed to death or not. And so whether it makes it onto the official death certificate is also uncertain. We do not have a national registry of toxicological testing. I personally, I think that would be helpful. But we also, we also just don't perform quantified or full toxicology testing on all overdose deaths. So we don't know about the xylazine we don't test for, and it's very hard to use the existing systems to track it. Next slide, please. But broadly, we know that it's really concentrated in that mid-Atlantic Philadelphia region and radiating out. So here are some charts on the increase of xylazine presence or detection year over year in this data set that I was alluding to of literal text medical examiner data that we work with, where we have, it's about 18% of the US population covered by it. And it just lists out everything that's listed on the death certificate, although some jurisdictions also provide additional information, such as full toxicology. And we basically, everywhere that we're looking for it, or everywhere that we're able to look for it, we see an increase, and we see, an exponential increase, and a lot, certainly again with Philadelphia, Maryland, Connecticut. I think the other thing that's really important to mention when we're talking about testing is specifically that, as you might expect, jurisdictions that see a lot of xylazine are generally more likely to do routine testing for xylazine. Connecticut, Philadelphia, they test every overdose death for xylazine. A jurisdiction like where I'm based, and xylazine is still very rare. Well, we think, because we're not testing for it, but you're not routinely testing for it, and there's a lot of reasons that might be. But I think that the clinical effects that Dr. Gendotra talked about are a really, really useful sentinel in terms of seeing the wounds and then knowing like that this is probably here. But we and everywhere we're looking for it, we are seeing increases. It's almost always with fentanyl, and as another caveat to the lab testing thing, some jurisdictions will do it where if an overdose comes back, if someone dies from what appears to be an overdose, and they do in-house or routine testing these deaths are going to mostly have fentanyl. And so jurisdictions that only do xylazine testing when nothing else is found aren't going to do that send out. So, in the sense that if someone dies from an overdose and it comes back, the tox comes back for fentanyl, say, okay, well, that's sufficient. And that's true. That often is sufficient to die. But they're not necessarily going to do that additional testing. And so for surveillance purposes, we don't have as clear of an idea where xylazine is present. I think the other thing I want to note is that we do see, as with overdose generally, we do see racial disparities in that Black and African Americans are overrepresented among deaths involving xylazine compared to white Americans. Next slide, please. And then the other place that you get, so when we're thinking about population level surveillance of drug trends, I like to think that there's 3 big buckets of information. There's what comes from mortality from postmortem testing, there's what comes from law enforcement, and then there's what comes from community interactions like treatment or drug checking or engagement in harm reduction. The first 2 slides I showed you were all about that first area of postmortem testing. This is about the law enforcement area looking at drug seizures involving xylazine. And so this was using laboratory data that's reported out by the DEA, showing how many reports of xylazine came through per place and how that has increased over time. And there's still, there is that really high concentration in that epicenter area. But, as that's from 2019 to 2022, when we see the updated version of this map, we're going to start seeing it more places. And how is it getting into the illicit drug supply? So some is definitely being diverted from the veterinary supply. Xylazine is fairly easy to procure as a veterinary medicine. And we can talk about the details of that and how they vary state by state. But other times xylazine is shipped directly to manufacturers, and we really don't have a great sense of what the relative source of that scoping is. So yeah, I'll turn it over to Dr. Friedman.
Great, thank you. So I want to start with a bit of a disclaimer, because a lot of the exact details about the harms of xylazine and how we should be treating those harms are a little bit controversial by the kind of implicit in the fact that xylazine has not been approved for use in humans. It's a very difficult thing to study. But I'm going to do my best here to synthesize the literature and what we do know, which is quite a bit. So I will say that the strategies that I'm going to argue here that we need to use to address xylazine actually apply broadly to a lot of the challenges we're seeing with an increasingly synthetic polysubstance drug crisis across North America. So xylazine is really a good example of how the transition from agricultural heroin to synthetic fentanyl has really ushered in this new wave of an overdose crisis that involves all of these different synthetic drugs across really numerous categories. So there's some examples, like with the shift to fentanyl, we're also seeing a rise in the co-use of methamphetamine together with fentanyl. There's also other synthetic opioids, such as nitazines, which have popped up in specific places in the US, as well as in the UK. Novel synthetic benzodiazepines, synthetic cannabinoids. And so what we're seeing is this really unique moment of kind of innovation in the illicit synthetic drug market, where all of this experimentation is happening in terms of the formulations of drugs that people are being exposed to. And there's a lot of novel health risks associated. And so these strategies we're going to talk about with xylazine, I think, also apply to some of these other challenges from these other drug categories. So as Dr. Shover mentioned, we really need better data. I think she did a great job of covering that. So I'm going to talk about this really briefly. But it would be really helpful to have comprehensive toxicology testing, not just for xylazine, but really for all of these synthetic drugs, right? Because, nitazines are not known, for example, which is this other category of synthetic opioids, also quite potent, that have not really been approved for use in humans, but we know that they're quite strong. They can cause overdose. And we know they're popping up in specific places, but we really don't have good information on the scope for a lot of the same reasons that Dr. Shover was mentioning, because we're not systematically testing for them. And so scaling up the systematic testing for kind of all of these novel synthetic substances is going to be a really important approach. And having specific codes for each of these substances that are used consistently would be quite helpful. There are more granular data systems, but even the data we have are often, released kind of on a long lag. So for example, there's a data system at the CDC called SUDORS, which does have access to a lot of detailed information, but it's not currently publicly available. It's really housed at the CDC and processed by them. And so if policymakers or independent researchers want to access that information, there can be challenges and some lags there. So I think there's also a lot of work that can be done in terms of data transparency around novel synthetic drugs and making sure that all the information we do have as a nation is kind of readily available. And then, overdose deaths are also this inherently kind of rare and lagged phenomenon. I mean, we know that there are, estimated 3 to 12 million people with opioid use disorder in the United States, or potentially more, depending on whose numbers you believe. And there's 100,000 deaths per year. And so it is still a relatively rare phenomenon. There's lots of non-fatal overdoses for each fatal overdose. We know less about those non-fatal overdoses. And so other forms of information that are interacting with people, while they're alive, it's like client-facing drug checking programs, testing for synthetics in clinical scenarios. These can give us more rapid and kind of, in some ways, more nuanced information, but those data sources are not routinely aggregated to the national level. And so kind of doing more to collect all of that information will be very helpful. And finally, I think we always want to be listening to the people who are the most directly affected by these problems. So I'm going to show some data now, basically the words of people who've been affected by xylazine, who've consumed it. What do they say about it, right? And so these are direct quotes from ethnographic studies. So here the question is, do you like the tranq dope, right? Meaning fentanyl cut with xylazine. And this is a person with a pseudonym of Henry, not their real name, who injects opioid, xylazine, methamphetamine, and cocaine. And they said, yeah, I like a good tranq fent bag, meaning fentanyl mixed with xylazine. Some people don't like it, but plenty of people do. It is sought after. Certain stamps, meaning brands printed on drug bags that are known for tranq, have better business. You know what I mean? I like it because fentanyl is such a short-lived high. It's a good high, but it's so short, and the euphoria, is over real quick, and you get sicker faster. See, the tranq extends the high. It gives the dope more of a heroin-like effect. It's a good rush with a heroin-like effect. But then other times, they put straight bags out there that are all tranq. You shoot it, you feel no rush, and you're just out. You're asleep for at least 40 minutes. You're sitting there 1 second talking, and the next you're waking up 2 to 3 hours later in a weird position, right? And so here we can see all of this nuance about, why people are intentionally, in some cases, consuming xylazine, why other people are hoping to avoid xylazine, and some of the health effects and the way that it's changing the lives of the people who are the most affected by this substance. Here's another quote from somebody just named E, who told the researchers, and they hate when they get it by accident. This is describing somebody who, the people that don't like to be exposed to xylazine, bad things will happen to them. They'll pass out somewhere, get robbed, won't remember what happened, all kind of crazy stuff. Because there's a lot of people out here that love tranq. I don't know why, because it literally puts you out, and that's when people rob your stuff. So this is kind of getting at the really unique characteristic of xylazine and alpha-2 drugs in general, is that they're really used for anesthesia. I mean, they're used to render a human or an animal unconscious, right? And so this is a very different effect from an opioid, which is used to relieve pain and cause euphoria. And so there's really this unique characteristic to xylazine that I'm going to talk about in a minute, how to manage clinically. And now on the topic of wounds and the soft tissue damage associated with xylazine, someone that we called Annie here, who's 25, injects opioids, xylazine, and methamphetamine, said, I got some friends out here that are really torn up by it. They have holes in them, abscesses. Basically, it's like the body is rotting. People here are losing limbs like with gangrene. Whatever they're doing with the tranq, everybody is getting these scabby sores all over their bodies, and many of them don't shoot meth. So it's definitely from the dope. And this is, again, this very consistent signal in the qualitative data that people can, robustly, consistently tell us that something is different about the wounds associated with xylazine. This has been a very tricky thing to study epidemiologically, but, in all of these different places, xylazine arrives and people describe the kind of difference that they're seeing in the people around them. So again, an important source of information about xylazine. So a really good way to know about xylazine is drug checking, which Dr. Shover is really the expert on this. But I'll just quickly summarize. Basically, what this can mean for for a client or for a patient is that most consumers of illicit opioids, if they are told that there's xylazine in the drug that they're consuming and they're really educated about the health risks, most will ultimately choose to avoid it. I think that's something that we've seen so far. And drug checking, right, giving people information about the drugs that are either in their body or in the substances themselves, can actually empower consumers to shift their demand away from more dangerous products. So it can be thought of as a form of harm reduction. Xylazine testing strips are a very low-cost solution. They cost about $1 per strip. And here you can see in the top right corner an example of a xylazine testing strip. They work very well on direct substances, so they can be used on like a drug wrapper or paraphernalia. They have not been FDA approved for use in urine, but I can tell you from my own experiences and from the experiences of many people and some nascent literature that they do often work on urine. There is a risk of a false negative because perhaps the strips aren't sensitive enough in every case for urine, but I can just tell you that they often are positive. So if you're not sure if there's xylazine in your local jurisdiction, using these strips on urine is a way that administratively you would be able to know if there's likely xylazine around you, even if you might not be able to use this for like perfect clinical information yet, although that is coming. More sensitive strips for urine are in active development. There's also FTIR spectroscopy is another. This is another technique. This is a machine that's shown here in the bottom right. This machine costs several tens of thousands of dollars, so it is certainly expensive, but it is portable and it can be used directly in a client-facing service environment. And so people can actually bring in their substances, have them tested, and know what they're consuming. So this is a way to empower people to know more about what they're putting in their bodies. There is gold standard laboratory-based testing with a variety of techniques, but these are send-outs. So this is, sending a sample of urine, sending a sample of substance, and waiting a few weeks to hear back, or a few days or whatever it is. And I think many of us who work with folks, who have a substance use disorder know that in that period you may have lost contact, or it's potentially less kind of actionable if you know that information with a lag versus, the strip or FTIR is maybe not the gold standard, but it's information you can provide to the client or the patient in that moment, which is quite helpful. So on the topic of overdose risk, this is a somewhat controversial kind of topic in the literature. People have different views. What I can tell you from my own experiences and from the literature that we do have is that xylazine clearly changes the way that fentanyl overdoses look, and they have some profound implications for management. So it's a fast-acting sedation via the alpha-2 receptor. It's anesthesia. It's people being unconscious, right? And this this kind of period can last 10 minutes or 40 minutes or potentially longer, depending on the dosing. And so we have to be comfortable. We still want to administer Narcan, right? Or naloxone or some opioid reversal agent, right? There are many options. But what is important is that the person, although you have administered an opioid reversal agent, the patient is likely not going to wake up immediately. So you can use pulse ox in the field or in a clinical environment and ensure that they're oxygenating well, and so they're alive, but they're not conscious. And so you have this very uncomfortable period where the person needs clinical management. They're not conscious. They can't protect themselves, but they are alive. And so managing that dynamic, I think, is quite new. It's something that's coming along with xylazine and something that may actually be an issue with a number of the kind of non-opioid synthetic drugs that are being increasingly involved in overdoses. Now, the degree of outright respiratory depression is controversial. Most of what I've seen, both clinically and then in the literature, is that after the administration of naloxone, people typically are respirating fine, but they're not conscious, so they need airway management, right? You need to kind of manage the airway, place them in an adequate position in case there's vomiting. You want to avoid bronchoaspiration, and so there's kind of this increased complexity of management. There is no approved reversal agent. In animals, there is an agent, Xylazine. However, no studies of this in humans, right? Xylazine is not even approved to be used or studied in humans, and so that's, I think, quite a complex notion to give that. Certainly in the field or in an outpatient setting, that would be quite complicated. So the overall, just to summarize, is still give an opioid reversal agent if respiratory depression is present. You don't want to overdo it. We're actually seeing that as the concentration of xylazine goes up, in some places, the concentration of fentanyl goes down. And so if we give the same kind of high dose opioid reversal agent, people actually wake up in a state of delirium with really severe withdrawal symptoms that really complicates management because they can rush off to go try and use more illicit opioids. And so actually, we want to very carefully titrate the minimum amount of opioid reversal agent needed to get them respirating well and no more, right? And that's a really important takeaway point. Manage the airway in the field, use field-based pulse ox is extremely helpful. And then in the hospital setting for really severe xylazine overdoses, we know that there are other supportive techniques that have been used in certain cases, like mechanical ventilation, fluid resuscitation, blood pressure management, all the basics of an ICU context, which in some cases is required, but a lot of the time in practice, xylazine-involved overdoses are managed in the field with an opioid reversal agent, with field pulse ox, and with kind of the presence of a good clinical team. I'll talk quickly about soft tissue damage. So again, hard to study epidemiologically, but in Puerto Rico, in Philadelphia, and now across the US, there's this kind of deep qualitative literature and sense that xylazine is associated with these atypical wounds, this kind of new degree of soft tissue damage. They have here's a photo from a case study on the right. They've often been described as ulcers, not abscesses. So like this kind of destruction of tissue without the typical progression of an abscess. And in some cases, it's tissue necrosis without infection. And what's curious is that it's been described in distal parts of the body or a completely different part of the body to where people inject, like they inject in their upper extremities and they get these wounds in their lower extremities, or even people who only smoke xylazine can sometimes develop these wounds. And so it's a really kind of scary and kind of difficult to understand process, but it's something that has been described widely. Here you can see a guide to caring for these wounds cited in the bottom of the slide. And treatment is often just debridement and wound care, and there isn't a need for systemic antibiotics. Although in some cases there is a need, right? And so that depends on the clinical judgment of the person treating the patient. Quickly, I'll say there has also been a different withdrawal syndrome described. So you can imagine if people are consuming fentanyl and xylazine throughout the day, you may be able to replace the fentanyl effect with methadone, right? Or with another opioid agent, medication for opioid use disorder, but people will still be withdrawing from the xylazine, and that's been described as causing anxiety, unease. And so that sense of anxiety can really complicate the MOUD treatment. And so people can unfortunately go back to using because their symptoms aren't being fully met. There's different agents that have been described in the literature that I've summarized here. I think clonidine makes a lot of sense. It's another alpha-2 agent that's also used for opioid withdrawal. And then there's using benzodiazepines, baclofen, trazodone, basically just manage the symptoms to make people comfortable so that they can hold off and not use illicit drugs during the transition as they get stabilized on something like methadone or buprenorphine. And finally, unwanted anesthesia, right? That we kind of alluded to this in the qualitative data. People are sedated, they're anesthetized, they're not conscious, and they're in public situations. And so that comes with a risk of sexual assault, traffic accidents, violence, physical violence. And so it's really important to kind of counsel people about these risks. And in terms of counseling, we want to, offer people drug tracking services, teach them about show them if they are being exposed to xylazine, either through clinical testing or through testing strips or whatever method we have available, counsel them on the risks of xylazine. Many people can be kind of motivated to stop using xylazine, potentially stop using illicit drugs altogether when they learn about xylazine in the drugs in their area, and just get people onto safer options, right? And that is, I think, a clear takeaway lesson across the sort of polysubstance, fentanyl, novel synthetic drug supply landscape, is that, these are really scary kind of new developments. Hopefully we can use them as motivation to get people onto safer clinically managed treatments, which is, I think, the goal. Thank you so much.
Thank you, Dr. Gandotra, Dr. Schofer, and Dr. Friedman for your presentation. At this time, we will begin the question and answer segment of the webinar. If you've not already done so, please submit your questions using the Q&A feature that's located on the bottom of your screen. Our first question: are the test strips more likely to give a false positive or a false negative for xylazine, or neither?
I'd love to answer this question. This is one of my favorite questions, and I'm going to give a slightly frustrating epidemiologist answer. That whether you're more likely to get a false positive or a false negative really depends on your prior suspicion or your reason to believe that it contains xylazine. There are very few real-world studies of xylazine strips that have come out. They're well validated in the laboratory setting. The lab that I work with, the federal lab I work with, has published some studies. There's been others by other groups that find that xylazine test strips consistently are able to detect xylazine presence at the concentrations they're listed at when compared to a lab standard. And that consistently, the older generations of xylazine test strips that came out in March 2023 consistently gave false positives when lidocaine was present. But newer generations don't seem to have that problem. I have a preprint making its way through peer review that my lab partners tested the newer generation and found that cross-reacting doesn't happen with the new ones, at least of the 79 different compounds they were able to test. Now, real-world data is still emerging. These tests only became available for purchase in March 2023. I think my lab was probably one of the first customers because they're much easier to buy now than they were at the time. And so we have a study that we're wrapping up where we've tested almost 500 real-world samples with xylazine, and we're finding, in the setting that I'm in Los Angeles, xylazine is very rare. So we really do trust our negative results a lot because generally we are expecting to have a negative result. But, sometimes we have the false negatives that we've had have been, the reasons that you would get a false negative, which I think in most cases is more concerning than a false positive. When you are, sometimes if the substance of the drug is very strange. We had someone bring a gum-like substance in, and that's just something that doesn't work for test strips very well. But we find that they work very well on tar heroin. They work well on powdered fentanyl. They work well on pills. But yeah, we have definitely not, we've seen false positives too, a few, with something like cocaine, which is probably usually reflective of the cocaine alphos having xylazine. But they're really sensitive. They work, you can test like drug residue, like just add some water to a drug wrapper and they work. So I think we're still understanding the exact specifications, especially as new lots come out, because there is variation lot to lot, manufacturer to manufacturer, as well as like improved, they change the antibodies on them to be more well targeted. But overall, I think they're like I think the specs on them are very good. All public health drug testing tools are imperfect, but I think that the xylazine test strips are quite good. Although, of course, if you're dealing with someone who has these classic xylazine wounds and they're doing the test strip and it's coming back negative, I mean, treat the symptoms, not the test, right? But I do think they're a good strategy and fairly easy to implement and use.
Thank you, Dr. Schofer. Our next question. With a rapid increase in dangerous adulterants in the opiate supply, such as xylazine, fentanyl, etc., has there been any discussion about a safe supply policy, such as prescribed heroin, in the United States?
There's definitely been discussion. Sorry, I know it's an unsatisfying answer.
Yeah, I'll jump in for a moment there. As we are guided by the Food and Drug Administration's approval process for medications for opioid use disorder. Most jurisdictions are going to be limited to what is FDA approved for opioid use disorder. So only those are the ones under consideration for funding through either payers or through government grants. Not to say anything about the future, but that's where we stand today.
Thank you, Dr. Schofer. Thank you, Dr. Gandotra. Our next question. In dealing with homeless encampments, is there a particular smell or any other identifiable sense that staff may be able to recognize?
So I can just say, smell, I'm not aware. Maybe Dr. Schober has read something about that. That's not something that's come up in any of the research that I've reviewed or conducted myself. I will say that when xylazine arrives to a particular area, I've worked in a number of like kind of concentrated drug use neighborhoods where xylazine has arrived. It's very noticeable, and there's a few things that you can look for. So the wounds are one. But then the other thing is people are going to notice that all of a sudden there's this very different characteristic to the quality of the what they feel after they consume drugs, right? And so if people are, unconscious to a new degree, finding themselves waking up in weird places, and especially using opioid reversal agent and not immediately waking up, even though they're breathing, as they would have previously, these are all clues. So I think kind of a lot of the things we talked about today are things that would jump out at you, I think. And if you're in doubt, then I would recommend using some xylazine testing strips and getting to the bottom of it.
Thank you, Dr. Friedman. Our next question. With xylazine being a metabolic, will it lead to false positive UDS results if a client starts working out or losing weight in early recovery? And if so, how long can that be expected to occur?
So real world data on xylazine in humans, how long does it stick around? Not a lot of data, as Dr. Schover mentioned, right? I mean, it's not really ethical to do a study of something that's not approved for humans in humans. But the data that I've seen suggests xylazine is metabolized pretty quickly. So that's actually one of the main ways I think you'd get a false negative is if the person has used too long ago when you go to, for example, do a urine test. I think pretty much if these tests are, I don't think there would be a concern of xylazine sticking around in the body for a long time after the person hasn't been using. I don't think that'd be the issue.
All right, our next question. Where can folks purchase xylazine test strips?
I mean, I buy ours from Wise Batch. The ones sold by BTNX and Wise Batch are, to my knowledge, the same manufacturer, and those have been the ones that have had validation studies published in the literature. There are other vendors. I don't know if Dr. Gandotra has like an official SAMHSA point about it, but like those are the two that I know have had any kind of validation so far.
I'll jump in again. There's a couple points I'd like to make here. One, the vendor that you mentioned, the BTNX, is available also on Amazon, so people can purchase directly. But it really also depends on your state. For instance, some states have been very proactive in being able or enabling providers and the community to access this tool, this harm reduction tool. In fact, New York has a statewide ordering system for xylazine test strips. They've also been very progressive in ensuring that individuals have access to this harm reduction tool. So I would say first check with your state. Your state may have resources and recommended sites through which you can order as well.
Our next question. Would you share your thoughts on strategies for educating both staff and the people we serve, given the changing knowledge and understanding of xylazine? This question was asked from an SUD provider that's in Philadelphia.
I think this can go to all of us, so I'll start, then let Dr. Friedman and Dr. Schover jump in. The first thing is with any type of condition, whether it's a substance use disorder or anything else, continuing education, whether we do it through the carrot or the stick of a licensing requirement or an incentive. I'll make a plug for SAMHSA's technology transfer centers, our provider clinical support system, as well as our addiction technology transfer center in particular, as places where there will be and there can be upcoming webinars on this. In addition, our harm reduction, our prevention technology transfer center is also engaged in this as well. The other side is that our grants with relation to our state opioid response grants and our harm reduction grants allow for not only the purchase of test strips, but providing that education training for our grantees. And in particular, the SOAR grants give over $1 billion out to the states, and they can utilize that as they see fit. So some jurisdictions that may have this need may be more apt to employ some of those mechanisms. In addition to that, there may be other mechanisms that particular jurisdictions have used to educate their community, whether that be town halls or fact sheets or things of that nature. Certainly anything that's available on SAMHSA's webpage or NIDA's in particular, as the two operational divisions that have done some work in this. All of that is free to use and download. And I would encourage folks, if they want to get those resources in terms of fact sheets and other advisories, to look at our web pages.
I was just going to make a plug for, I think, in terms of like reaching a broader community of folks who use substances, a really helpful approach that I've seen work specifically for xylazine is basically going through peer navigators or kind of peer mentors or peer coaches. So, finding people who have a little bit, have a good relationship with, the harm reduction clinic or the clinical providers or whatever it may be, who kind of have a foot in both worlds and use the expertise of those folks to put the educational materials you have in the words of the people who are most affected by the issue. And so I think that can work really well, right? Have workshops, get people all in the same room and just put the basic, most important information in really simple and easy to understand terms, that you don't have to be a doctor or a researcher to understand, and use the expertise of the communities that are actually being affected to kind of get the wording right and get the message right.
Yeah, and I completely agree with that. What I'd add to it is I think, around the topic of like our understanding and knowledge about xylazine is evolving pretty quickly. And I think, I just think generally for expert credibility, it's helpful to sort of be humble and honest about what we know and don't know. I generally think that there's plenty of things that I think we've covered today that are pretty well established about xylazine, and then a lot we also don't know as well. But really putting it into people's language and also listening to what people are telling you. I mean, one example locally we had is there is one particular area of Los Angeles that they have been seeing wounds consistent with xylazine for a very long time, and it took a while for us to actually get drug checking to happen in that location and confirm this. And throughout that, we're still providing like, look, here's what you do. Like here's how here's what we would recommend. assuming that xylazine is present. And a lot, as Dr. Friedman has covered, a lot of this applies to other drugs. People who inject drugs get wounds for other reasons too. But not kind of denying that like lived expertise, and also, being very clear about when we can verify it. Yeah.
All right, our next question. Do you have any recommendations on a specific protocol for treating xylazine withdrawal?
I can tell you that there is no kind of approved or standardized protocol for this. Certainly not, at least not one that I'm aware of. I mean, there are some medications that are consistently talked about in the little amount of literature we have, right? So clonidine has long been used for opioid withdrawal treatment for management, and it's also an alpha-2 agonist. So it makes a lot of sense to use that, but we can't say like this is the kind of approved, well-studied protocol. But that is an agent that comes up a lot. Benzodiazepines are discussed a lot, and then just other symptomatic management. But unfortunately, there's not a great, I sort of listed on the slide the medications that have been described in the literature, but this is an area where we really need, kind of clinical trials and innovation to describe what is really the optimal approach. And so far, the evidence base isn't there.
Thank you, Dr. Friedman. This concludes our Q&A portion of the webinar. As a reminder, the recorded webinar and PowerPoint slides will be made available and sent to participants at a later date in the near future. Next slide, please. We just want to thank our presenters for taking the time to be here this afternoon, and we want to encourage everyone that has attended the webinar today to complete our evaluation. The evaluation can be accessed by using the QR code that's located on the screen that you're seeing, and we will also drop the link in the chat. But we do ask that folks complete the evaluation, as your feedback helps us shape future webinars. Next slide, please. For states who are interested in accessing technical assistance, SAMHSA has made TA available via the State TA Project. To access those services and resources, or to learn more about what may be available, you can email samhsastateta@jbsinternational.com. Next slide, please. And with that, we want to thank everyone for being here this afternoon. And again, a big thank you to our presenters. Our evaluation link is in the chat. So again, we do want to challenge folks to complete that evaluation. It's a big help for our team. And that link will be available and live even after the webinar ends. But with that said, wishing you all a wonderful rest of your day. And we look forward to seeing you again very soon at an upcoming webinar. Thank you.